start let's start from where we left off. We were already through with the first and second stage inhibitors. And so the next portion in that cell wall synthesis has to do with the joining together of the peptidoglycans. That is the transpeptidation reaction. So the carrier has brought the peptidoglycan from the inside of the membrane to the outside so that the peptidoglycans can be joined together. So basically what happens then is that with this peptidoglycan over here, when it gets to the outside, it has to be joined to another peptidoglycan. And that joining occurs at the level of these 5 glycine molecules. So if we say NAG and NAM, and then we have 3 and then 4 and 5 amino acids. So the 5 glycine molecules will join the number 4 amino acid over here, and the last amino acid will then be lost. Okay. And that joining of the glycine to the 4th amino acid there is what is called the transpeptidation reaction. That is, one peptidoglycan joins to the next peptidoglycan with the loss of the last amino acid on that second one. And that is what goes on all around the cell membrane for you to have the cell wall formed. And the transpeptidation reaction is carried out by a transpeptidase, and that's what the 3rd stage inhibitors inhibit. So they inhibit that enzyme transpeptidase. And that inhibition is actually by acylation. They just form an acyl group. They acylate the peptidoglycan, the enzyme. So that's how you will have the wall synthesized. But before your inhibitors of transpeptidase can work, they have to bind to your PBP, penicillin binding protein. Even though it's called penicillin binding protein, it is not only for penicillins, it is for all your beta-lactams. And all your beta-lactams are 3rd stage inhibitors. So the 3rd stage inhibitors are your beta-lactams. And the beta-lactams you can divide into 4 main groups. So you have your penicillins and cephalosporins and monobactams and carbapenems. So we'll start off with the penicillins. So we'll start off with the penicillins. The penicillins have certain things in common. We know that they have the same basic nucleus, the 6-amino penicillinic nucleus. So they have the basic nucleus, which has a thiazolidine ring, you know, a 5-membered thiazolidine ring, and that thiazolidine ring is then joined to a beta-lactam ring. Cephalosporins have a six-membered thiazolidine ring. Okay, so the penicillins have that in common: 6-amino penicillinic acid, it's actually 6-beta. Okay, and if you're allergic to one, you will be allergic to all of them. So they have cross allergenicity. Okay, so they have that in common. However, there's something called ampicillin rash. Ampicillin rash is not an allergic reaction. Okay? It's a side effect of ampicillin on the skin, you know, that does not really respond to antihistamine. If you had an allergy and you use an antihistamine, you know, you get relief. But ampicillin rash, you have to use a corticosteroid to manage it, because it's not your regular histamine-related allergy. Okay, so if a patient has, or they're taking ampicillin and they show up with a rash, and they claim that, okay, that's evidence that they have allergy to penicillins, you can just convince them that it's not, or explain to them. So, but if you're truly allergic to one, you'll be allergic to all of the penicillins. And we always say that about 2.5 to 5% of people who are allergic to penicillin will be allergic to cephalosporins also. Okay, so that's that relationship. Okay, and they all bind to penicillin binding protein 1 and 3. That's one exception. The only exception is that PVR that we wrote last time, number 18 here. PVR. PVR binds to PBP2. It doesn't bind to 1, it doesn't bind to 3. It only binds to PBP2. Okay, so that's one exception there. And they're all bactericidal, and they produce a time-dependent, you know, bactericidal effect. If you remember last time, we mentioned that your vancomycin would also be time-dependent. Your teicoplanin will be time-dependent. And if we can go a step further, all your beta-lactams, all of them are also, they also produce time-dependent, you know, bactericidal effects. Your macrolides are, they are protein synthesis inhibitors. Usually at the regular doses, they are bacteriostatic. But when they do produce a bactericidal effect, it is also time-dependent bactericidal effect. Okay. So those are some examples of drugs that will give you time-dependent bactericidal effects. And last time we mentioned some drugs that will be that will be concentration dependent. You know, your daptomycin, dalbavancin, ritavancin, telavancin, all of those will give you a concentration dependent bactericidal effect. Your aminoglycosides will give you concentration dependent bactericidal effect. Your polymyxins, since we just mentioned some of them, the polymyxins would also give you a concentration dependent bactericidal effect. Your fluoroquinolones would also give you concentration dependent bactericidal effect. Which other big group? Okay. Oxazolidinones. Those would give you, time dependent, just like your beta-lactams. All right, so those are some big classes there. So those are the similarities that you get with your penicillins. Now, they are dissimilar. In other words, they have dissimilarities. And based on those dissimilarities, you can classify your penicillins. Okay, they are dissimilar sometimes in the plasma binding protein capability, whether they are acid stable or not. In other words, can you administer them orally or not? Whether they inhibit or they are not susceptible to penicillinase, and then of course based on the spectrum they are dissimilar in terms of their spectrum. Okay, so because of these dissimilarities, you can classify the penicillins into these different groups. You have the parent compounds, which are called benzyl penicillins. Okay, that'll be one class. And then you have your PRPs, penicillinase resistant penicillins. Okay. And of course, you have your aminopenicillins. Okay, aminopenicillins, those are sometimes called broad spectrum penicillins. Okay. And sometimes they're called ampicillins because all of them get converted to ampicillin in the body. So, and then of course you have your ESPs, extended spectrum penicillins, and then you have your amidinopenicillin. And there's only one member of that amidinopenicillin group. So examples for your parent compounds or your benzyl penes will be pen G, of course. So you have pen G and you have pen VK. Those will be your parent compounds. And your PRPs, you have some examples like, I won't use methicillin, and let me just write it. Methicillin, and then nafcillin, oxacillin, cloxacillin, dicloxacillin, and there's another one that is called flucloxacillin. Okay, so all of those are examples of your PRPs. Methicillin is no longer available in the US. Okay, but when you say MRSA, that's what you're referring to. Methicillin resistant Staphylococcus aureus. So that term is still used, okay? Methicillin resistant Staphylococcus aureus. But the drug itself, methicillin, has been removed from the market. So when you use this term MRSA, it is still referring to all the PRPs. Okay. So flucloxacillin is mainly available in Europe and Australia and stuff, not here, but it does exist. Okay. So those are your PRPs. Aminopenicillins, that's your ampicillin. That's your ampicillin and amoxicillin. The other three have been removed from the market. All this hetacillin, cycloxacillin, vacampicillin, those have been removed. So right now we just have ampicillin and amoxicillin as your PRPs. And your ESPs, the only one that is still viable or that you can still get is piperacillin. So all this azlocillin, meslocillin, ticagrelin, carbonicillin, all of those have been removed. So it's only piperacillin that is available. And it's not available by itself. It comes combined with a penicillinase inhibitor. Okay. And imidinopenicillins, there's only one agent in that group, and that's your Pavia, that number 18, Pavia. Okay, so those are the groups. And I think on your study guide it says compare and contrast the different subgroups of penicillins. Okay. If we look at the route of administration, your pen G and pen VK are administered orally. Okay. Today, pen G is no longer used as an oral formulation. If you want to use the oral, you have to use pen VK. Okay. Because the absorption with your oral pen G is very erratic. You don't know how much you're really going to get into the system. So that's why it's no longer used or made. If you want to take it orally, you have to use pen VK. So That's for the benzyl penicillins. The other ones that can be administered orally, you have your PRPs. So your PRPs, your oxacillin, clox and diclox. Those can be given orally. Apart from orally, oxacillin can also be given parenterally. IM, IV. Nafcillin is most often given IM, IV, but there was an oral preparation of nafcillin that was made. Okay, so we still have to list it as being available for oral administration, but it's most often given IM and IV. So that is that. We'll come back to other routes of administration of the benzyl penicillin when we take that as the representative drug to discuss the pharmacology of the penicillins. Aminopenicillin, we know both of them can be administered orally, but ampicillin, apart from oral, can also be given IM and IV. Amoxicillin is given orally only. Okay. The ESPs, like we said, it's only piperacillin, but it's not even available by itself anymore. And amidinopenicillin, that PVR, can be administered orally, 200 milligrams. It comes in a 200 milligram tablet form. So that's in terms of oral administration. We'll come back and discuss amidinopenicillins, that is Pavia, and we'll come back and discuss your PENG as representative agents. Okay, so in terms of resistance to penicillinase, okay, so your PRPs will be resistant to penicillinase, resistant penicillins, and so will your PVR, amidinopenicillin. So that is also a penicillinase resistant agent. However, it is different from these PRPs in the sense that PVR works on gram-negative organisms, especially gram-negative aerobic bacilli, or the ones that you call your Enterobacteriaceae. So those are your gram-negative aerobic, gram-negative aerobic bacilli, or the ones that we sometimes refer to as the KIPS agents. Klebsiella, Enterobacter, E. coli, Proteus, Providentia, Serratia. Those are all enteric gram-negative aerobic organisms. So in answering that guideline question, if you're comparing them, amidinopenicillins, they'll be resistant to penicillinase, but will mainly work on gram negatives, whereas all your nafcillin oxacillin, all of those will work on gram-positive agents. Okay, so that's in terms of resistance to penicillinase. The other classes are not resistant to penicillinase. And if we're talking about penicillinase, we have some agents that are penicillinase inhibitors. As you say, from there, 22 to 27, these are all penicillinase inhibitors. And so you can always attach a penicillinase inhibitor to a penicillin product. Let's see if I put there. Okay. Well, okay, those are penicillinase inhibitors. And so you want to find out what you have in Zabaxa and your Zosyn. Barbamare, okay. Also find out what's in Premaxin. Even though Premaxin contains a carbapenem, the carbapenem in Premaxin inhibits penicillinase. Okay, so it has an ability to inhibit. Albicaz. With Cabrio. Let's put Unasyn in there also. I didn't put Timentin in there because Ticasilin has been removed from the market, and what it contains was Ticasilin. Okay. And then we can put Augmentin. So those are combination drugs that contain a penicillinase inhibitor plus a beta-lactam. The beta-lactam could be a penicillin, it could be a carbapenem. Yeah. So you need to know those products. So that's in terms of penicillinase activity or rejection. All right, so you can compare those groups also in terms of their plasma protein binding. If you look at the plasma protein binding of the parent compounds, it's within the range of 60 to 80% plasma protein binding. The average for PENG that is taken is usually 65%, ppb. So that's for your parent compound. The PRPs have the highest as a group have the highest ppb among your penicillins, and they're always 90 and above. So all this nafcillin, oxacillin, cloxacillin, dicloxacillin, the PBP is very high. So that's the comparison. The aminopenicillins as a group are very low. They're about 20%. So the amoxicillin, ampicillin, those are about 20%. We don't need to talk about ESP because it's only piperacillin, and piperacillin itself is about 16%. So it's low. Amidinopenicillin is usually about 5 to 10% plasma protein bound. Okay. So that's in terms of the PRP, the plasma protein binding, and route of administration, or which one is available for oral administration. That is stability in an acidic medium in the stomach. So that's that comparison in a way. And then we'll go and look at the spectrum, because that's another point of dissimilarity among your penicillins. So with the issue of spectrum, we can, let's see. Can basically look at the spectrum for PenG and the spectrum for ampicillin. The one for ampicillin is part of your study guide. You see it there. PRPs up here, they have a very, very narrow spectrum. They're just effective against staph and strep. And that's it. It's just staph and strep. That's their spectrum. So ESP we don't have to consider anymore. Amidinopenicillin, the spectrum is just those Enterobacteriaceae, that is the gram-negative aerobic bacilli that are enteric. If you see ESBL in your reading, what it refers to is extended spectrum beta lactamase. Okay. So the spectrum of amidinopenicillin, that PVR drug, okay, is mainly the Enterobacteriaceae that are resistant to an extended spectrum beta lactamases. See, your penicillinases are beta lactamases. Your cephalosporinases are beta lactamases. We refer sometimes to penicillinases as beta lactamase 1, cephalosporinase as beta lactamase 2. That enzyme, when it's released by other agents, you can see it referred to as extended spectrum beta lactamase. So amidinopenicillin, or PVR, because there's only one in there, it covers ESBL producing Enterobacteriaceae. So that's its spectrum. Okay, so we're basically left with your PenG and ampicillin. So if we look at ampicillin, maybe we'll let's just quickly look at the antibacterial spectrum of Pen-G. So we know that Pen-G is effective against staph and strep. Okay. That would be your gram-positive aerobic cocci, Staphylococcus and Streptococcus. We know that it is effective against club, that is Corynebacterium, Listeria, and Bacillus, like Bacillus anthracis. Okay. And Bacillus anthracis is the cause of what? The causative agent of? Of what? Bacillus. Okay, so because the full name is Bacillus anthracis, it causes anthrax. Okay. And what are the two monoclonal antibodies that you know, that you remember from last time, that can be used to treat anthrax? Okay. Anthrax. Anthem. Okay. Those are monoclonal antibodies that can be used to treat, anthracis or anthrax caused by Bacillus anthracis. If you want to use another drug, Cipro is very effective against your Bacillus anthracis, so it can be used to treat anthrax also, Cipro. Okay, so Corynebacterium, Listeria, and Bacillus anthracis, those are your gram-positive aerobic bacilli. They're not cocci. And then if you get to the Neisseria group, which will be gram-negative aerobic cocci. Okay? So Pen-G is effective against both Neisseria meningitidis, which causes meningitis, and against Neisseria gonorrhoeae, which causes gonorrhea. So it is effective against both of them. And then you go to the gram-negative aerobic bacilli, enteric versus non-enteric. Okay, and in terms of the enteric, your Pen-G will not be effective against any of them. So it will not be effective against your so-called KIPs that we wrote up there, the Enterobacteriaceae. It is not effective. Okay. But non-enteric, it's effective against Streptobacillus. Remember Streptobacillus moniliformis, the one that we said will cause rat bite fever. Okay. In this country, in the Orient, it will be Spirillum minus. So Streptobacillus moniliformis is effective against that. And Pen-G will be effective against Pasteurella, one of your Ella sisters. If somebody gets a cat bite, they can get infected by your Pasteurella species. So you can use Pen-G to treat cat bite fever, if that Pasteurella is present. You would actually prefer to go to the cephalosporins. They're more effective, especially third and fourth generation cephalosporins. Very effective against your Pasteurella species. But, okay, so these two are non-enteric, but they are gram negative. They're gram negative. They are non-enteric, but they're bacilli, not cocci. Okay. So then, if you go to the anaerobes, Pen-G will be effective against your Peptococcus and Peptostreptococcus. Okay. Those will be gram-positive anaerobic coccus or cocci. Okay. So it will be effective against those. And and then Pen-G will be effective against your bacilli. For instance, it will be effective against some species of Clostridium. It does not work against Clostridium difficile, which is very difficult to handle. But other Clostridial species, like Clostridium tetani, Clostridium perfringis, it will be effective against those. And it will be effective against your actinomyces or actinomycetes. Actinomyces covers both Actinomyces israeli and your Nocardia species. Okay. So it will be effective against those. Now those are gram positive, but they are anaerobic. Okay. Bacilli. And then if you go to the anaerobic gram-negative bacilli, those are your Fusobacterium. So it will be effective against your Fusobacterium species, and then again your Bacteroides species. Okay. And Pen-G is also effective against spirochetes. So if you're talking about your Leptospira, species, it will be effective against that. That's the one that causes the Weil's disease. So it will be effective against that. It will be effective against Treponema. Like Treponema pallidum, which causes syphilis. So it's effective against that. And then it's effective against Borrelia. Borrelia burgdorferi, which causes Lyme's disease. Okay. So that's Pen-G. It covers all those organisms. So these three, Leptospira, Treponema, Borrelia burgdorferi, Borrelia recurrentis, those ones are spirochetes, spirochetal agents. Okay. So we can rub this off. So we're still talking about your penicillins there. So the only other group you have left would be the aminopenicillins, that is amoxicillin or ampicillin. If you look at the antibacterial spectra, let's just take one. Antibacterial spectra for ampicillin. Take that as a representative agent there. So just like Pen-G, it will be effective against staph and strep. It is not effective against clubs. Okay, so ampicillin will not work against clubs. Okay, but it works against Neisseria, so it can be used for gonorrhea, if you will. Now, in terms of the enteric agents, here also it does not really work very well against those enterics, but it does have some activity against what we call PRES. That is Proteus, Proteus species. Your E. coli works against E. coli. It works against your Salmonella, like Salmonella typhi, and it works against Shigella. Okay, Salmonella, Shigella, E. coli, and Proteus species. It works particularly against Proteus mirabilis, which is Indo-negative. Okay, Indo-negative, Proteus mirabilis. That's what your ampicillin works the best against. And then when you get to the bacilli, that is the non-enteric agents, your ampicillin would work against your Campylobacter species. Campylobacter, okay, works against them, and it works against your H. flu, Haemophilus influenzae, so it will work against that one. It will work against your Pseudomonas species, and it works against your Acinetobacter. Aeromonas. Not so much against Acinetobacter, but a whole lot against your Aeromonas species. So That will be your ampicillin. And Gardnerella, one of your Ella sisters, can also respond to your treatment with ampicillin. Okay. When it comes to the anaerobes, with anaerobes, ampicillin is very effective against actinomyces, be it actinomyces israeli or Nocardia asteroides, the one that looks like a star. Like a star, Nocardia asteroides. It grows like a star. Look at it. Actinomyces or Actinomyces israeli, that's the one that causes lumpy jaw. Actinomyces israeli, like Israel. That's the one that causes lumpy jaw. Okay, so that's what your ampicillin will be effective against. Now, if you give ampicillin with sulbactam, right here, ampicillin with sulbactam, you will extend the effectiveness of ampicillin against some organisms that ampicillin by itself would not ordinarily hit. Okay. For instance, when you give, you might as well just name it. It's right here. When you give Unasyn, which is sulbactam, sulbactam plus your ampicillin, then you see that sulbactam covering things like your things like your gram-negative aerobic cocci, Moraxella. See? Gram-negative aerobic cocci, you have only two organisms to worry about. They are Neisseria species and Moraxella species. Those are the only two. Moraxella is also called brown hamela. Okay. So when you use Unasyn, you can actually cover Moraxella infection. But if you use ampicillin by itself, it would not hit that organism. So giving it with the inhibitor, the penicillinase inhibitor, you actually extend its effectiveness. It's extended also to Clostridial species. You get coverage with Unasyn, but not with ampicillin by itself. So you get coverage even with Fusobacterium and Bacteroides. In other words, these last three here will be covered by Unasyn, but will not be covered by ampicillin alone, by itself. Francisella will be covered by Unasyn, but not by ampicillin alone. So you actually do extend its coverage when you give it concurrently with a penicillinase inhibitor. Okay. So those are the antibacterial spectra of the penicillins. So we've covered all the groups. Okay. And so what we'll do now, say a word or two about that new drug, Previa, and then quickly go through PEN-G for the pharmacology of the penicillins. So amidinopenicillins we used to have a drug called amdinosilin, Coactin. That was the brand name, Coactin. Amdinosilin was a member of this amidinopenicillin class, but it was removed from the market. And now you have a poem, if you will, poem, because now we include the E and the M. You have a POM derivative of that old amdinosilin. Okay. And that POM stands for pivalloyl oxymethyl ester. Okay. So the POM derivative of the old amdinosilin is what is now available as that Previa. Right there. Okay. And that Previa, of course, is administered orally, like we said, and it is an ESBL inhibitor, or extended spectrum, beta-lactamase inhibitor. And we've seen its antibacterial spectrum, which is mainly gram-negative, Enterobacteriaceous. And we said it is administered orally, and it comes in 200 milligram tabs. And the usual dosage, it is usually administered on a TID basis. You can give it every 8 hours or 3 times a day. And it's used for the management of UTI. If you're using it to treat catheter-related UTI, you can give it 2 tablets, which will mean 400 milligrams. You can give 400 milligrams PO Q8, and that can be given for about 7 days, so 1 week. Okay. If it's uncomplicated UTI, you can give 2 tablets once, that is like a loading dose, and then you give 1 tablet, that is 200 milligrams, every 8 hours. And we know that the drug has a low plasma protein binding. It's about 10 to 20%. The PPB is 10 to 20 plasma protein binding. Its half-life is just like most of these penicillins. Penicillins' half-lives usually range between 1 to 3 hours usually. So it's within that. It's like 2.5 to about 3 hours in terms of its half-life. And it is mostly excreted through the urinary system. You know, about 80% of it is excreted through the urinary system. And the adverse effects will be just like any other penicillin. So we'll talk about the adverse effects of penicillins in a second. So those are just some quick notes about your PIVIA. It is a prodrug, really. Mesalamine. If you go down here, you see mesalinam right there. If you take the PIV out, so it's a prodrug for that mesalinam. Okay. So those are just preliminary things. And then as for amdinopenicillin, that. CRPs. Okay, so to look at PENG as a representative for all your penicillins, so we can discuss some indications and adverse effects. Okay. PENG, like penicillins, mechanism of action, it will bind to PBP3, 1 and 3, and then it would inhibit or acylate your peptidoglycan, that is transpeptidation reaction. So basically we inhibit that transpeptidase. That's the mechanism of action for all of them. Again, the only exception there will be PIVIA because that binds to PBP2 instead of 1 and 3. Okay. If we look at the ADME for PENG, PENG today will be administered parenterally, IVIM. It is no longer administered intrathecally, even though that was one of its routes of administration. And the reason you don't use it intrathecally anymore is because it was causing a lot of arachnoiditis, an inflammation of the arachnoid. Which is one of the 3 layers of your meninges. So intrathecally, people don't use it anymore as such. So it's not for therapy anymore. And you can see it installed, that is, instilled in the eye to manage gonorrhea in neonates. Okay, when the baby is first born, if the mother had gonorrhea, that gonorrhea could actually infect the eyes of the newborn baby. So you can use a solution of Pen-G, you instill it in the eye to manage that. Silver nitrate is also used for that. You know, gonorrhea neonatorum, that's the condition. Also, you know, you can use silver nitrate. You can instill tetracycline, that would also work in the eye. You can instill erythromycin, that also works. But you can use a solution of your Pen-G to clean out the eyes. You instill it in the eye to manage that gonorrhea. So by installation in the eye, and you can use a benzathine Pen-G. Intramuscularly. Benzathine Pen-G is not to be used intravenously. Okay. In fact, if you see it, you will not give it intravenously. It looks like milk. Okay. It's called a repository preparation. Repository preparation of Pen-G. So that's benzathine Pen-G. And also you have Procaine Pen-G. That is also a repository formulation of your penicillin G. The repository form is to be given intramuscularly only. You don't give it IV, you don't give it subcutaneously, it's IM only. The product, well, there are two products currently on the market. You'll see, and these are brand names. Bicillin. You see Bicillin LA, and then you see Bicillin CR. Okay. Bicillin LA contains only benzathine Pen-G. Bicillin CR contains both benzathine and Procaine Pen-G. Okay. So those are the products that are available on the market right now. You can also administer Pen-G into the cavity of the chest in some situations. So those are the different routes of administration of Pen-G. We already know the plasma protein binding, and the half-life, like for most penicillins, is like 1 to 2 hours. They're always low like that, about 1 to 2 hours. And we look at distribution. It can go into the liver and the lungs. It can be distributed into those fluids, synovial fluid. It can get in there. It can be distributed into the bile. In fact, the bile is an area of distribution for your so-called isoxazoline penicillins. That's your oxacillin, cloxacillin, dicloxacillin. Those are your isoxazoline penicillins. And also nafcillin. So nafcillin can also be distributed into the bile, just like your PENG, just like your isoxazoline penicillins. I'll just mention one thing about piperacillin here. Piperacillin can be distributed into the bile, and it also goes, of course, into the kidneys, and it gets excreted very slowly from both cavities. Very slow excretion of piperacillin from the bile and from the kidneys. So I can go there. We have to mention distribution to the kidneys and to the breast milk. So your penicillin can be distributed to all of those tissues. It only gets into the CSF when there's an inflammation of the CSF. Okay, so it does not readily get into the cerebrospinal fluid unless the patient has meningitis. When the meninges are inflamed, that's when it gets into the meningitis. Okay. Your study guide mentions something about drug-to-drug interactions involving penicillins. So this would be one of them, the probenecid. Probenecid can inhibit the secretion of your penicillin into the renal tubules, so that the concentration will remain high in the bloodstream, and that's what you take advantage of in gonorrhea. You can give probenecid like 30 minutes before giving a penicillin. So the probenecid would inhibit or decrease the renal excretion through tubular secretion, and so the plasma level will stay high. So that's one of the answers to your guide then. Okay. So that's your distribution and excretion. Of course, excretion is mainly through the renal system. It's primarily through the renal system. A little bit can come out in the bile. There is biliary excretion, and a little bit can come out in the breast milk. So breast milk, bile, but primarily renal excretion. Okay. So indications, we'll just mention some. Okay. You've been exposed to most of them. So in terms of indications, you'll just be talking about pneumococcal infections, meningococcal infections. I'll be Other ones, streptococcal infections. And that streptococcal infections will include ANF, acute necrotizing fasciitis. Acute necrotizing fasciitis, and that's another flesh-eating bacterial infection. Okay, so ANF, and that's part of your study guide also. So all this strep throat, scarlet fever, you know, that can be caused by your streptococcus species. All of those will be in there. And we can talk about syphilis. You know, Treponema pallidum, of course, causes syphilis. And we've talked about the actinomyces infection, actinomycosis, or your lumpy jaw. That's a general, common name for actinomycosis. Lumpy jaw. Anthrax, we'll discuss that. Bacillus anthracis, which causes anthrax, and clostridial infections. You know, infections caused by Clostridium perfringens, Clostridium tetani, lockjaw, the common name for tetanus. Okay, so Clostridium tetani can cause your lockjaw. So lumpy jaw is actinomycosis. Lockjaw is tetanus. Okay. And you can use penicillin there. Cat bite fever. So, it's not only cat bite, the drug NG can also work in human bite fever. Okay. Cat bite fever, also rat bite fever. Mentioned that Pasteurella features very well in there. In human bite, you have a particular agent, Streptococcus aeruginosus. That is what is recovered in about 45% of human bite fever. NG fortunately works very well there. Ichinella species is also recovered from human bite. You can also see staph, like Staph aureus, recovered from there, from human bite. You know, Ichinella corrodens. You can also see Corynebacterium recovered from human bite fever. So all of those you can use PenG. And then of course staph infections, including toxic shock syndrome, TSS. You know, you can penicillin is used in such a situation. Of course, gonococcal, gonorrhea, so Neisseria infections. Say it being used there. The diabetes, the diabetes leg syndrome or disease, Penji or penicillin works there. Cystic fibrosis, penicillin can work there, particularly that nafcillin. Nafcillin helps very well in the management of your cystic fibrosis. Lyme's disease. Lyme disease is another indication. Listeriasis, that is Listeria infections. So a lot of them. You can see a penicillin used in such conditions. Physospirochetal infections, or what you call trench mouth. Physospirochetal infections. You can see a penicillin used in that situation also. So we have a whole bunch of indications for penicillins. The infection is caused by Corynebacterium diphtheria. So you get diphtheria, one can use penicillin in such situations also. So several indications, and we'll just quickly look at the adverse effects. Adverse effects, number one, hypersensitivity reactions or allergic reactions, and that can go anywhere from just your regular rash all the way to anaphylactic shock. I mean, you can have bronchospasm, you can have wheezing, and hives and all those. So hypersensitivity reactions. Then number two, GI. It will be non-specific GI, nausea, vomiting, diarrhea, sometimes black furry tongue. Black furry tongue. And if the diarrhea is extensive, or if a patient has a history of getting a lot of diarrhea when they take antibiotics in general, or when they take penicillin in particular, there are some people that advocate for advising the patient to actually use a probiotic before they take the antibiotic. I don't give that advice. Personally, I don't. And the reason I don't is because the probiotic can correct the situation, that is, can prevent you having a lot of diarrhea for a short period of time. But it takes a much longer time before your microflora returns to normal. So in the long run, you're really not benefiting the patient. So that's my reason for not giving that advice when I dispense an antibiotic. And I still stand by it. You have certain over-the-counter probiotics that one can use. Say, there was a product called VSL number 3. The VSL are the initials of the people that originally made the probiotic. Okay. Then they had a fight. The person that actually was the starter of the company had a fight with the other two, and basically they went their different ways. And the original guy now made Visbiome. So Visbiome contains what VSL number 3 used to contain. Okay, so this is a strong probiotic preparation. You'll see it in your refrigerator in the pharmacy, you know. And now it is actually used clinically for treating irritable bowel syndrome, IBS. And it is also used for treating ulcerative colitis, you know. So, but anyway, it's a high concentration of these organisms that you will find in there. So probiotics that you see over the counter, and then your Visbiome, they always contain 3 major types of organism. You have Streptococcus, okay, that's Streptococcus Thermophilus, okay, that's usually in there. And then you can see Lactobacillus in those probiotics. Lactobacillus acidophilus, that's one. You can see Lactobacillus bulgaricus. That's another one that you can see in your probiotics. You can also see Lactobacillus brevi, Lactobacillus Lactobacillus agalacticus. You can see it also in there. But anyway, Lactobacillus species, Streptococcus species, Thermophilus, and then Bifidobacterium. You can have Bifidobacterium brevi, you can have Bifidobacterium longis, Bifidobacterium bifidum. That's another one. So it's mainly these 3, those three species that you see in your probiotics, this biome or the regular one that you see over the counter. To be frank with you, strictly speaking, you only have two, because this bifidobacterium used to be, classified as a lactobacillus species also. So, but anyway, so if that diarrhea is troublesome, some people would recommend a probiotic to change the microflora of the stomach for that. So those are GI-related adverse effects. Then some adverse effects can include hematopoietic adverse effects, such that you see a positive Coombs test. And it could be direct positive Coombs test. You can see bleeding, thrombocytopenia, leukopenia, even agranulocytosis. All of those can be present as hematologic adverse effects. Okay. What we used to call extended spectrum penicillins, we only have piperacillin left in there. That group used to cause a lot of bleeding, and so you have interactions with Coumadin. Okay, so nafcillin also interacts directly with Coumadin. So that's hematologic adverse effects. And you can have renal type adverse effects, where you see oliguria, scanty urine formation, and you can see some proteinuria. They can lose proteins in the urine. That can be possible. Okay, so that's renal. Then you can see electrolyte imbalance. If the penicillin is a potassium-containing penicillin, like PenVK, then it's possible to get hyperkalemia, okay? Which means one has to worry about administering the PenVK concurrently with drugs that would normally give you hyperkalemia. Your ACE inhibitors, your ARBs, those can give you an increase in potassium. Your birth control pills that have drospirenone in them. Remember, once it ends in renin, it can always elevate your plasma potassium. So drospirenone, eplerenone, can also interact with PenVK in that manner. Canagliflozin can also raise your plasma potassium. So all of those. But on the other hand, piperacillin can reduce your potassium level. So then you have to worry about interaction with your thiazides and high ceiling diuretics like Lasix. So piperacillin can affect or can lower your levels of potassium. And then if you look at the other electrolytes, like say sodium, penicillins usually contain a lot of sodium, especially the long-acting agents. So you will see the increased risk of having congestive heart failure or an increase in blood pressure because of the retention of sodium. So those could be drug-to-drug interactions there. Okay. And CNS adverse effects are minimal these days since people don't use penicillin intrathecally anymore. So you can just get some lethargy, headaches, fatigue. Those are CNS related adverse effects of your penicillins. Okay. Pain at the site of injection, particularly when you administer penicillin intramuscularly. If you want to give it IM, you would actually prefer to use that repository formulation. That would be less painful. And supra-infection. Whenever you give a drug that has a broad spectrum of activity, it can give you supra-infection. And the manifestation of that supra-infection is sometimes CDAD, Clostridium difficile associated diarrhea, or it can be just a form of colitis or pseudomembranous colitis. So you can see all of those as possible adverse effects of your penicillins. Some other interactions that we can mention. If you give penicillin concurrently with another drug that inhibits bacterial growth, that is something that produces a static effect, that is bacteriostatic effect. The bacteriostatic agent will decrease the effectiveness of your penicillin. In other words, the microorganism will not even get to the level of making cell wall. So really, you're losing any effect that Pen-G or penicillin can give you. So concurrent administration of a bacteriostatic agent with a bactericidal agent will result in a decrease in the effectiveness of that bactericidal agent. Aminoglycosides tend to activate or synergize a beta-lactam antibiotic. So concurrent administration of an aminoglycoside and a beta-lactam can result in the synergy or synergism of that penicillin. But if you mix them together in an IV bottle or whatever, you can have a decrease, that is an antagonistic effect. That is, the aminoglycoside can precipitate. So that synergism occurs when you are talking about in vivo mixing, because in vitro mixing results in antagonism. Okay? So in vivo mixing, synergism. In vitro mixing, antagonism. And some penicillins, particularly the aminopenicillins, that is ampicillin and amoxicillin, they can decrease the effectiveness of your oral contraceptives. So that can lead to an unwanted pregnancy. So that is another interaction that one can refer to. Okay. Covered enough there. Let's give 2 quick points here before we get off the penicillins. You don't stop the administration of penicillin to a patient who is taking Pen-G for syphilis just because they exhibit what is called Jarisch-Herxheimer reaction. Okay. So Jarisch-Herxheimer reaction, it's almost like just an immediate collection of syndrome that the patient gets if the patient has syphilis and they're taking Pen-G for the first time. They can have that Jarisch-Herxheimer reaction. All you have to do is give aspirin. Just 1 tablet of aspirin will clear that reaction, so you don't have to stop Pen-G. Now, the other point that we can stress under penicillins is that when you're using penicillin to treat an infection that is caused by group A beta hemolytic strep, okay? Group A beta hemolytic. Or the so-called Streptococcus pyogenes. You always have to remember that if GN occurs, glomerulonephritis, if you say glomerulonephritis, or if you say, if you see an effect on the heart, or the patient exhibits some cardiovascular issues, those are not directly due to that organism. Glomerulonephritis is a complication of Streptococcus infection, that is by group A beta hemolytic strep. So GN is a complication of that infection. It is not caused by that organism. Okay, so GN or rheumatic heart fever, which, let's see, those two conditions are not caused by the Streptococcus species, that is Streptococcus pyogenes or group A beta hemolytic strep, but they are complications of that infection. Let's put that in there. Can we just leave the penicillins? Monobactams, the ones Aztreonam, Paramonam, and Trichomonam. So these three are your monobactams, and Aztreonam, of course, is the one that's taken as the representative agent. Aztreonam binds to only PBP3. Okay, it doesn't bind to 1 and 3, it binds only to 3. That's the way it produces its transpeptidation reaction inhibition. That's its mechanism of action. And Aztreonam has a very narrow spectrum. It is only effective against gram-negative aerobic organisms. So it works against Neisseria, and then it works against the Enterobacteriaceae, the KIPs, Klebsiella, E. coli, Enterobacter, Proteus, Providentia. Okay. And then it works against the one that we call APHA, Acinetobacter, Pseudomonas, H-flu, and Aromonas. So APHA, that's its spectrum. Okay? Neisseria, and then your KIPs, and then APHA. That's the spectrum. So narrow spectrum. Even though it has a narrow spectrum, it still produces your pseudomembranous colitis, or your CDAD, through supra-infection. So it still produces those. And you administer it IV, IM. Occasionally, it can be given by inhalation, especially in cystic fibrosis patients. Okay, cystic fibrosis patients. And the uses, you can use it for respiratory infections that are caused by those organisms that we just mentioned. You can use it to manage gynecological infections. You can use it to manage gonorrhea, and all that. Urinary tract infections, it works very well there. Septicemia caused by those organisms, yes, you can use it to treat those. So, what else can we say about Astronam? Its half-life, its half-life is again between 1 and 3, usually about 2 hours. It has a plasma protein binding of about 56%, so it's just medium. And excretion is primarily through the renal system, about 60 to 70% through the renal system, and about 12% will go out through the feces. So that's about all we can say about Astronam. And we can go on to the carbapenems. The carbapenems, you'll see them there, imipenem, and doripenem, and artapenem. I think I've listed there over here. So from 31 up to 37. So those are your carbapenems, and we know that the one that will take as the representative will be imipenem, and we know imipenem comes with cilastatin, so you will have as a result Premaxin. Okay. And we know that Premaxin or imipenem by itself has one of the widest, antibacterial spectrum ever, because it is a derivative of thinamycin. Thinamycin itself is not available as a drug, okay, but its derivative, which is imipenem, is available as a drug, but imipenem has to be combined with cilastatin so that it is not broken down by dehydropeptidase 1. Okay, if you look at the spectrum of activity of Premaxin, we said it will be very, very broad. So it's effective against Staphylococcus and Streptococcus. It will work there. As wide as it is, it really does not affect your clubs. Premaxin is not effective against your Corynebacterium, Listeria, and Bacillus anthracis. So it's not very effective against clubs. Okay, it works against your Neisseria species. It even works against Branhamella species, that is your gram-negative aerobic cocci, and against the bacilli, it works against all gram-negative aerobic bacilli that are enteric, that is the Kipps organisms. except for Salmonella, Shigella, and Yersinia. So it works against all those enteric organisms, except Salmonella, Shigella, and Yersinia. That would be Yersinia enterocolytica, because Yersinia pestis is a non-enteric organism. Okay. So it works against all of those. And when you go to the non-enteric agents, it works against your APHA organisms, you know, Aeromonas, Pseudomonas, and your H. flu, and your Acinetobacter also, it works against it. It also works against Gardnerella. So it works the APHA then plus Gardner. So it will work there. And Peptococcus, Peptostreptococcus, yes, it works. It works against Clostridium, but not against Clostridium difficile. Okay, so it works against Clostridium species, but not against Clostridium difficile. Okay. And then for the bacilli that are anaerobic, it is effective against your Fusobacterium as well as your other agents, Bacteroides, you know, species. So that's how broad it is. Route of administration, it is given, well, maybe we should compare it to the others. That's what your study guide requested, that I should compare. So we'll say Premaxin over here, and Meropenem there, Artapenem, and Doripenem. Okay. So we can look at half-life. We're talking about about 1 hour, about 1.5 for Meropenem. For Artapenem is 4 hours, and for Doripenem is also about 1 hour in terms of half-life. You know, if we look at plasma protein binding for your Premaxin, it will be about 20%. So it's about 20% plasma protein bound. Meropenem is very low, it's about 2. Artapenem is like 85 on the average. You know, you can go all the way to 95% in terms of plasma protein binding for Artapenem. And for Doripenem is about 8%. So that's the range there. If we say excretory route, they would all go out through the renal, but Artapenem is both renal, and it also has some mammary or breast route of breast milk, route of excretion, and doripenem is also renal. If we look at dehydropeptidase, okay, so it will be a yes for Pramaxine, but in all of these will be no, no, and no. They don't need a dehydropeptidase inhibitor in them. And then you look at PBP 3. Imipenem does not bind to PBP3. All the others bind to PBP3. All the carbapenems have a low affinity for PBP2A. Okay. PBP2A is found on your MRSA, MRSA, MRSA. And that's why you don't want to use carbapenems to treat MRSA infections. Okay. If you have MRSA infection, you go to G5, that is 5th generation cephalosporin. You use this ceftaroline. We have anyway. Ceftaroline, right here. This is ceftaroline and ceftibiprole. Those two are 5th generation agents, and they work by binding to PBP2A precisely. So, but not your carbapenems. Carbapenems don't also bind to PBP5 very well. Imipenem binds to PBP5, but not effectively. And what elaborates or what exhibits or what has PBP5, your VRE, vancomycin resistant Enterococcus. Okay, so you don't want to use a carbapenem to treat VRE infections because they don't bind to PBP5, readily. And then we can compare them in terms of dosing or dosage. If you're giving Pramaxine, you can give anywhere from 250 milligrams to 1 gram, up to 4 times a day, that is up to Q6. So one can use that. For meropenem is 1 gram, like TID, 3 times a day. Ertapenem, because of that high plasma protein binding and longer half-life than the rest of them, you can give it 1 gram IV QD. Okay, let's put this in terms of Pramaxine, you can give IM IV. Meropenem, we gave IV only. Ertapenem, IM IV. And if you give doripenem by itself, you give it IV. Dosage for doripenem is about 250 to 500 milligrams IV, and you give it about every 8 hours. So that's the comparison thing that we mentioned. The adverse effects that one can see with meropenem, You can have cardiovascular adverse effects, which would be just things like your congestive heart failure, myocardial infarction. It can produce all of those. Arrhythmias. Arrhythmias is another one that it can produce. So those are cardiovascular adverse effects. The number one adverse effect of Premaxine is CNS related. That's the number one above everything else. So you can get seizures. So if a patient already has or is prone to epilepsy, you don't want to give them, Premaxine or Imipenem. Okay. So seizures and headaches, those are the top two. Others that you can see can, include insomnia or somnolence or depression, all of those nervousness, agitation, restlessness, all of those can be part of the CNS related adverse effects of Imipenem, but the top two will be your seizures and headaches. So CNS related adverse effects. Effects on the GU, genitourinary tract, you can see an elevation of BUN, blood urea nitrogen. BUN can go up. On the GI, it would be the usual: nausea, vomiting, diarrhea. Some people can experience constipation also. But it's usually nausea, vomiting, diarrhea. There are no specific adverse effects that you can get. It can affect the hematopoietic system, and you can get the, hematopoietic, but it's actually more of the liver, but it bleeds into the bloodstream. So you can get your positive, direct and indirect, both direct and indirect Coombs test. Okay. Positive, direct, and indirect Coombs test. That can occur. You can see elevation of the liver enzymes, ALT, AST, they can go up. Lactate dehydrogenase, LDH, can go up. Creatinine or creatine phosphokinase levels can go up. So those are all essentially related to the liver, and in some ways to the hematopoietic system. Since Premaxine has a very broad spectrum, remember it's a derivative of tinamycin, okay? So you can expect supra-infection to occur with that agent. And the supra-infection can then lead to CDAD or pseudomembranous colitis. So that can be expected. Phlebitis. Phlebitis is also something that occurs with that drug. You can get phlebitis that affects the veins. One can say that hypersensitivity reaction. Hypersensitivity reaction can also be a manifestation of its adverse effects. That that one can get. So those are the commonly observed ones, but remember, CNS is absolutely number one for the carbapenems. And then, of course, you can have microorganisms that will produce carbapenemase. You know, that is a beta-lactamase that will be resistant to the actions of carbapenems. And that is what you would call CRE. So they can elaborate carbapenemase, which can destroy your carbapenems. And so that'll be carbapenem resistant Enterococcus. And usually, I mean, in actuality, that E, that is Enterococcus, can actually refer to Enterobacteriaceae, because your so-called KIPS organisms that we mentioned, Enterobacteriaceae, they can elaborate that inhibitor of carbapenem, or they can elaborate carbapenemase. And how do you treat CRE? Well, you can use timoxilin. Okay. You can use timoxilin. You can use tixobactin, Bactin. That you can use tigecycline. That will be a type of tetracycline. Okay, fosfomycin, you know, a four-stage inhibitor that we mentioned earlier. That also can be used. Fosfomycin. And you can use your polymyxin. Okay. So all of those have been shown to be effective against CRE infections. Okay. Let's see, quickly leave that and finish up with a word or two about your cephalosporins. The cephalosporins you can divide into generations. Generations 1 to 6. The use of structures to divide them now is not very useful, because many of those drugs have been discontinued. You know, loracarbev is gone, moxilactam is gone. You know, so it wouldn't make sense to actually use structure. So one can still use generations. And Fetroja is believed to be a G6. So You can put it as G5 or G6, but that's the only one that is like a G6. And that's the one that that has a chelator. It's like a conjugation or a conjugate of a cephalosporin, usually the third generation cephalosporin, like ceftazidime or ceftolozane, with a chelator of ferric ion. In other words, Fetroja has a component part of it that can chelate ferric ion. Some organisms need iron for survival. The iron that is readily available in the body or in the environment is in the form of ferric, not ferrous. Not F2, that would be ferrous. So ferric ion. And you have a catechol moiety which can bind to ion in the ferric state. So when the organism sees ion in the ferric state, it readily absorbs that ion in the ferric state, not knowing that an antibacterial is attached to that ion in the ferric state. That's why you say it's like a Trojan horse. The organism sees what it needs to survive, which is ferric ion, and it readily absorbs it, but what's behind that ion is an antibacterial agent that will then destroy that organism. Okay. So that's essentially how Fetroja works. Fetroja is basically just used for infections caused by KIPs, okay, your Klebsiella group, or your Enterobacteriaceae, okay, and it works when those organisms are causing something like complicated UTI, or causing skin and skin structure infections, or causing other infections that are related to pneumonia. Okay. So if you're talking about healthcare associated bronchopneumonia, okay, healthcare associated bronchopneumonia, you can use your Fetroja. And even if it's community associated or community acquired pneumonia, you can use that Fetroja. And then skin conditions. If you have your triple SI, you skin and skin structure infections, as long as it is caused by a susceptible organism. You can use your Fetroja. And we know that Fetroja is usually administered parenterally, so you can give it IV or IM. But the problem with Fetroja is that it produces some severe adverse effects. It can actually cause atrial fibrillation, and that's serious, atrial fibrillation, and it can produce your increase in Clostridial production, that is pseudomembranous colitis or CDAD. It can produce that. It can affect the electrolytes. You see a drop in magnesium, and you can see a drop in potassium. So all of those can be present. So it causes all those severe conditions, and then it can produce a lot of CNS-related adverse effects. The insomnia and somnolence and seizures, so it has a lot of those bad adverse effects. Quickly jump on to, so but anyway, that's a generation 6 agent. If you want to classify it as that, I would just put 5 to 6 because it's still not established yet. Then ceftriaxone and ceftaroline, those will be a 5, that is G5. And those are basically used for skin and skin structure infections, and also for pulmonary infections, pneumonia type things. Ceftaroline, we know, is a prodrug. It's a prodrug, so once you inject it, because it's given IV, once you inject it, it gets converted to its active form. And the conversion is not due to your cytochrome P450 system, because ceftaroline is not metabolized by your cytochrome P450 system. It is metabolized by some phosphatases. Phosphatases in the body, that's what will convert the inactive to the active form of the drug. So it has about 88% of the administered dose going out through the urine, and that's about 6% of it that will go out through the feces for that ceftaroline. And the plasma protein binding is about 20%. It's about 20%. And the half-life is about 2.6 hours for its half-life. And the indications, again, like we said, skin, that is SSSI, skin and skin structure infections. And it can also be used for pulmonary infections like pneumonia. especially when those infections are caused by staph and strep, and then by what we say hike. Haemophilus influenzae, Klebsiella, E. coli, by hike organisms. So staph and strep, and then hike organisms. You can use ceftaroline. The usual dosage is about 400 to 600 milligrams Q12. 400 to 600 milligrams Q12. If you're using it for, say, CAP, community-acquired pneumonia, it will be used for just about 7 days. But if you're using it for triple SI, then it is used for 7 to 14 days. So for much longer time. And when we say staph and strep, remember it is very effective against MRSA. That's what we mentioned when we were talking about that PBP2A, under your carbapenems. So it binds to PBP2A, those fifth generations, they bind to PBP2A, and then they inhibit transpeptidation reaction. So that's the indication for your ceftaroline. Ceftobiprole is essentially the same, another fifth generation agent that you use for skin infections and pulmonary infections. Okay, cefepime, cefprom. Okay, those two are fourth generation agents. And cefepime is the one that is most often used among the fourth generation cephalosporins, and that drug is effective against CAPS. The CAPS organisms, I think we went through those last time. Okay, especially when those CAPS organisms are causing nosocomial infections, that is hospital-related infections. Okay, so that's the main use of your fourth generation agents there, particularly cefepime. And the other Cefdemia, Cefditorin. Okay, I think this was on the study guide, I believe, in terms of the dosage. Okay, you can use it at 200 milligrams on a BID basis. So you can use that. And it's mainly used for skin infections, okay, and pulmonary infections. Okay. Ceftobiprole, all of these are three up to there. Okay. All Well, there's a G3, you know. And cephalexin, cefadroxil, and cefazolin. Those ones are G1. Cefuroxime is a 2, and cefotitan, cefixime, okay, 12 and 14 are also 2. Cefixime is Suprax, that's a G3 in terms of classification. Okay, so I think it requests that you know the usage of cephalosporins in surgical procedures. Okay, CABG, coronary artery bypass grafting, CABG, coronary artery bypass grafting. For that, you will use Ancef, cefazolin. That's a G1. Okay. Cefazolin, that's Ancef. That's the one you will use for that preparation of the patient for CABG. We're talking mainly about cephalosporins here. If we were talking about just any antibiotic, then one, as an alternative, one can use vancomycin, in that situation. But anyway, let's keep it to cephalosporins. So Ancef will be the agent there. If the patient had a hip injury or they need to get hip replacement or joint injury, okay, one can use Ancef there again, or Zinacef. Okay, Zinacef is cefuroxime, which is a G2. Up here. Cefuroxime. So you can use Ancef or Zinacef in that particular situation. If you're trying to have a surgery, a genitourinary type surgery or lower GI, then one can go to the cefamycins. And the cefamycins are Cefixime. Okay, let's see. Okay, Cefixime right there. No, that's not where I put it. But anyway, one can use the cefamycins, and cefoxitin is one of them. Cefamycin. That's methoxin. That's one that one can use. And one can use cefotitan. For the genitourinary type infections, surgical procedure, if you want to do that. Okay, if it's hysterectomy, if it's for hysterectomy, then you can use cefamycins, and you can also use that Ancef, cefazolin, right there. is for hysterectomy. So it will be the cephamycins or your Ancef. Okay. Now, if you were handling or trying to do a surgical procedure, that is related to the dental system, or that is having a dental procedure, the cephalosporins that one can use for prevention of infection during dental procedures will be cephalexin, which is Keflex. It should be a G1 right there. Number 16, cephalexin. One can use that. Ancef can be used, which is also a G1, and one can use Rocephin, which is a G3, ceftriaxone. Ceftriaxone, number 10 here. So one can use that also. So that will be your Rocephin. Duracef, which is a long-acting G1, can also be used in that kind of situation. Okay. Oops. I'll just mention maybe 2 more, and then we'll call it quits. Skin and skin structure infections. That is, if a patient has cellulitis, for instance, you will use a G5, okay, ceftaroline or ceftriaxone. So that'll be for cellulitis. You can use Spectracef. Spectracef is good for skin and skin structure infections. That is triple SI. Okay. And it can be used also for ABEC-B, acute bacterial exacerbation of chronic bronchitis, acute bacterial exacerbation of chronic bronchitis. So it can be used for skin, it can be used for pulmonary infections or ABEC-B. Okay. And it's administered orally. That's in dosage of 200 milligrams BID. Okay, diabetic foot infection. Diabetic foot infections, you can use a G3 or a G4, and then you combine that with either Flagyl or a fluoroquinolone. Okay. So G3 or G4 along with a fluoroquinolone or Flagyl, or with clindamycin. So clindamycin, fluoroquinolone, or Flagyl along with a G3 or G4 if you have that diabetic foot injury. I mean, there are other agents that one can use. All those penicillin-related drugs that have the inhibitor of the enzyme penicillinase, you know, ones like that, Unasyn that we mentioned, you know, you can use that. You can use piperacillin with, and you can use Zosyn. Let's just put it that way. So, Augmentin, you can also use Augmentin for the management of that diabetic foot injury or infections. Okay, that's how far we're able to go. The others we touched on the last semester or whatever. Questions? No questions? Okay. Add to that study guide the pharmacology of Pavia and the pharmacology of Fetroja. Okay, so who's the class rep? You guys have to decide on the class rep. That's in your student handbook actually. For every class you have to have a class rep. So make a decision, get the information to me. I don't know if you have to vote or what have you. And who has the list? Thank you.